it will be very, very crucial, the investigation about predictive biomarkers. And in this sense, tertiary lymphoid structure seems to be the most robust biomarkers of immunotherapy in sarcoma context, and several publications reported from Petitpré and Antoine Italiano seems to be very, very important. The presence of TLS detected by pathologists is clearly correlated with a higher probability of response in these patients. So this is beyond any doubt. What is the limitations of TLS? The first limitation is that maybe the technique can vary, and we will need expert pathologists in detecting this TLS, which is the presence of mature dendritic cells, CD3 lymph cells, and B cells, CD20 positive cells. So maybe we will require some time for this training from the pathologist, because this can be obviously a limitation, but it seems it's not highly complicated, let's say, and we will use in the upcoming months as a standard approach for advanced setting. Another option is true that the TLS proportion of patients that can be detected, or the estimation is around 20% of sarcoma patients can express this biomarker. So maybe 80%, the remaining 80%, some of them can respond to immunotherapy. So we have developed as well a genomic signature that can be predictive for immunomodulation in the context of soft tissue sarcoma. And this is a 7-gene signature that have been built considering those dynamic changes in gene expression from baseline to week 13 in the Immuno-Sarc trial. And then the signature was also validated at the baseline, which is able to predict the different progression-free survival. We have validated the signature as well in the SARC trial of patients treated with pembrolizumab. So maybe genomic signature will be very convenient as well in order to establish a higher probability of activity with immunomodulation. Actually, with this 7-gene signature positive, the median of progression-free survival is above 11 months, but if it's negative, it's below 2 months. So this seems to be very powerful in distinguishing two different populations. So, and the validation also detected two different populations, but with these clear, different polarized figures. So it's obviously this is a very important field of knowledge, and because, as I mentioned, some patients with sarcoma can be benefited even with exhibiting a cold microenvironment. And then we have the chemoimmunotherapy, as I mentioned before. And for this specific strategy, we don't have any prediction. Still, we don't have any prediction, but this will be very important. We have the dynamic prediction, and we can say that after 2 months, the increase in blood of HMGB1 predicts longer progression-free survival, for instance. So, but still, this is not at baseline. It's after 8 weeks. Okay, so but the knowledge is increasing in the recent times, and I think this will be very, very interesting. Also, the Milan team, Sandro Pasquali, has recently reported the convenience to explore in the high-risk localized disease different areas in the surgical specimen after neoadjuvant chemotherapy, and in those areas called high inflammatory, it seems the performance of this scoring of this area is good enough to predict significantly better disease-free survival, for instance. And again, this is a dynamic changes, but at the time of surgery, we can say to the patient, okay, this seems to be good enough for thinking that the disease-free survival will be good. So this is obviously a very topical issue, and several investigators are dedicating a huge effort in defining predictive biomarkers of immunomodulation in the sarcoma context, and this is obviously very welcome.